but the patient's interpreting it as massive pressure. Okay? That's where I think we shouldn't just make assumptions that they're going to tell us something or that we know best. I start the conversation as an open dialogue right away. I need your feedback to help you. In fact, I need you to help me help you. Right? And if they're not on board with that, I'm going to be more annoying than I am on a daily basis because I'm going to be peppering them with questions. If I can't trust them to be a reliable reporter, then I need to be on them like crazy to make sure that they're not letting me do something that could be harmful. Okay? In many of the manual therapy fields, there's just too many belief systems that you have to use super deep pressure to get something out of this person. And a lot of people buy into it. But conversely, I think I need to honor somebody's belief that more pressure is necessary. And I'm not going to exceed what I think is safe, but I'm willing to negotiate the levels of pressure with you so that you feel I'm doing something that could be helpful and certainly not doing something that can be harmful. But has anybody ever gotten craniosacral therapy? Yeah. Craniosacral therapy is I'll be careful with this one. There's a lot of modalities out there that have really lousy stories to support them, but apparently they have research that says it's valid. In the beginning, craniosacral therapy is, Robert, you're filming this one, and it's like, I don't know if I want that out there, but anyway, craniosacral therapy says 5 grams of pressure is enough to do the work we need to do to release your cranial sutures, to get your craniosacral rhythm going back again. 5 grams of pressure is the weight of a nickel. 5 grams of pressure when somebody does it on me makes me want to just scream because they're not doing anything according to my internal barometer, right? But here's a weird thing. When somebody comes back from a session, they had a session with us, and they come back and say, boy, I was really sore from that last session. A natural thing the therapists think is, I must have worked too aggressively or too long, right? And it's a nice thing to say. Yep, I always take ownership. I'm sorry if I worked too aggressively or too long. But early in my career, I used to do some cranial work and took craniosacral training, which was spending an entire session working with 5 grams of pressure on a patient. Like, you can't even rest your hand on a patient because that's too much force. And a patient would come back to me from a session, from a cranial session, saying, I felt like I got run over by a bus after you worked with me last time. Now, I couldn't reach into my pocket and say, well, we must have worked too aggressively. So cranial taught us a story that we used to tell people, and they'd go, oh, okay, I get that in some way, right? But ultimately, some people get sore. Ultimately, some people like heavy pressure, and some people like light pressure, and some people like to give light pressure or heavy pressure. Instead of me dictating what should be done, I want to find out what you feel is most useful for you. And that's where I'm going to stay. And it's a constantly fluctuating bar of pressure and negotiation. All right? Okay, so we're going to move into the laryngeal region right now. We're going to start off, I told you earlier today that we're going to start off, tomorrow we're going to talk about carotid arteries. We're in the neighborhood of the carotid arteries right now, all right? But we are in the neighborhood of a lot of arteries every time we treat a person. Carotids tend to be important, but so are all the other arteries, right? We're going to be working regularly in areas where there's blood supply, both arteries and veins, as well as some really important nerves, which is more reason to make sure my patient is not only capable, but willing to give me feedback. So I don't use too much pressure. Because no matter what we do, harm is possible, correct? A patient can sue us for real or imagined injuries. Walking into the room with a patient carries risk, correct? So all we can do is be prepared, know our cautions, red flags, have a full level of communication, okay? I also think it's important, too, to not have a patient who won't say anything, right? That sets us up for a higher level of danger. I need my patient to report back to me what they're feeling at all times. We're going to be working in this general region right in here. Here's where I feel my work begins to overlap dramatically with the laryngeal manipulation field. Although we're not doing that manipulation, when you take a look what happens inside when you're doing laryngeal manipulation and when you're doing what we're doing here, you're seeing almost the same effect on the scope. Okay? We're going to be starting off with a very specific handhold in specific direction, at least to start from right now. We're going to be doing this technique twice. We're going to do it once in supine, laying on the table, and then we're going to do it once in sitting. And we might even be able to get to the sitting one today. Okay? And what would I do this technique for? In your syllabus, every technique has a couple of indications printed in there. I fought myself long and hard because a lot of people wanted indications. They want a protocol. They want a decision tree. If the patient has this sort of disorder, I'd use this sort of technique on them. And I resisted that strongly. And I finally gave in to the other voice in my head that said, do it. Okay? But I do it with a grain of salt. If you looked at that indication list and you didn't see your diagnosis on there, would that mean you wouldn't use it? That's what I was hesitant about. To me, knowing which technique to use is a matter of where is the issue felt? Where is it noted by the patient? That's where I'm going to put my hands, and I've got a variety of different techniques to use in that area. So you may use this technique for muscle tension dysphonia, for globus, for dysphagia, for base of tongue tension. Lots of tongue tension issues you're going to connect with, at least beginning when we start moving in that sublingual region, okay? And fill in the blank for a lot of other conditions that I don't even know about that you folks work with on a daily basis. So is there anyone in the room, you're not coming up yet, but I want you to chew on this for a moment while we're doing the demo with the skeleton. If you've got some issues primarily in this part of you, maybe you can be my demo for this one. But can we come on up with the camera? I'm going to be going with my skeleton model now. Handhold, I told you I want you to be extemporaneous. I want you to be dancing a bit, but where you're starting your handhold is going to be fairly well defined at this point, okay? And before we go anywhere, let's do some basic anatomy. Wouldn't it be fun if our patients had removable thyroid cartilage? Just take them off for cleaning and we'll put them back on. But underside of the mandible, you've got hyoid bone right up in here, the thyrohyoid membrane, thyroid cartilage. Does anybody do work where you do manipulation of the hyoid bone? Anyone? You do? Yeah. Last year I took Jacob Lieberman's class, I told you. And in Jacob's class, he had a video that he was sent by one of the online anatomy programs. I think it's Walt or something like that. Well, what it was a video of a freshly dissected hyoid out of a human being. Okay, and the video shows the freshly dissected hyoid, and then they show a gloved hand. They show the gloved hand coming in like this to the hyoid bone and using inward force like that. And they showed the hyoid bone, in essence, dislocating at the two joints here. Now, I saw that video and I went, I took gross anatomy. And my hyoid on my 83-year-old female cadaver was a bone. And what I was seeing in this video were 3 bones with basically a joint there and there. And it's like, that was really bizarre because it's not what I remembered. And I thought maybe that was a baby hyoid that hadn't fused yet, but it was a full-size hyoid. And by the way, this is a little small for the normal hyoid that you're seeing right here. So I didn't say anything in class. And the message of that video was, don't squeeze too hard. right? And I went home and I went on Dr. Google and PubMed and everything, and I couldn't really find anything on that. So I emailed Jacob and he said, you know what, I was sent that video and I'm not sure about it. So we both went down the rabbit hole of PubMed and neither one of us could find anything. And I put something out there on my Facebook group about this conundrum that I was in, and a therapist who took my class from Ireland sent me a paper that's in your Google Drive folder that shows that the mean age of fusion of the joints at the hyoid is between 20 and 50. That's the mean age of fusion when hyoid bones become a hyoid bone. And just think about that next time you're grabbing hold of the posterior horns of somebody's hyoid and using a type of pressure that might feel a little strong. I don't mean to scare you, but I want to scare you, okay? It's not the way I remembered anatomy, because I dissected out an 83-year-old hyoid, and that's what you see in the anatomy books. But according to at least that one study, that your 50-year-old patient may not even have a fused hyoid bone yet. All right? So when we do this area, yeah, we might feel the hyoid. You might be in the area of the hyoid, but please don't put a lot of posterior pressure or pressure period on the hyoid. Okay? All right. So I think lessons like that are important, just like carotid lessons, right? But not thinking in terms that, boy, I didn't learn that in school at all, and I was really glad I saw that video. So here's where I'm going. My patient's laying on the table in front of me. I want to get my hands in this general area right there. You're going to maybe improvise once you get going, but here is your starting point. So my thumb and base of thumb are below the jaw, right? I don't want to be so close to the jaw where it feels like I'm just dragging the jaw. I want to be just a little bit toward the feet in the jaw. I don't want to be too far back on the spine, because if I'm too far back and if I try to do a lateral shearing, I'm going to be shearing the spine instead of shearing the larynx. The way I guarantee that is if I position my hand so that this part of my thumb right there, the base of the thumb, so that I can get a pinch of this sublingual region right there, then I know I'm in the right area. Because when I do that, my hands are sitting forward of the spine. See how they're anterior to the spine right there? There's the spine. The heels of my hand are forward of that. All that does is guarantee that my hands have the ability to really explore this whole lateral laryngeal region and not be forcing my way into the spine here. I grab hold, and you'll see when I bring somebody up here, I'm going to do a little sublingual pinch right here, and that's just to ascertain that my hands are in the right starting place. That I don't have to keep pinching unless it feels really useful and familiar and relevant to the patient. But what we're going to do then is, one of my favorite concepts with this work is to move from macro to micro, meaning macro, a larger grip. I have access from sublingual up here through posterior lateral hyoid, thyroid cartilage, down through the cricothyroid joint, and on some people with a shorter neck, almost into the clavicle region. Okay, you got a big piece of real estate you're covering. And as I explore and shift side to side or shift forward, I'm looking for frozen chicken. I'm looking for areas that interest me. I'm looking for doorbells that start ringing off my patient's awareness, where their eyes brighten up and they say, whatever you just did, that's part of that swallow, voice, globus, whatever feeling that we're looking for. Okay? If you want to, you can come right back up here into the suprahyoid base of tongue sublingual region and start working with vocal tension, for tongue tension issues, any kind of sublingual region and posterior pharyngeal wall issues in through that area. It's a big piece of real estate you're going to cover, and you can go from macro into micro without ever moving your hands. Do you know what I mean by that? I find something in the macro and I narrow in to the micro, and I start asking my patients questions. If they say yes, that's familiar and that's relevant, I stay in the micro. If not, I go back off into the macro with a larger surface area, and I keep seeking and searching. Okay? Okay, shut down. So, anybody want to be my crash test dummy for this one?